Okay.
I think we can hear. It's pretty small.
Can you hear pretty well?
We'll ask you to put up with.
All right.
Okay.
So it's a great honor for me to introduce Dr. Gwen Vogel Mitchell. Dr. Mitchell is at DU, Department of Psychology. She's one of the core supervisors in the International Disaster Psychology Program at DU. She's a clinical psychologist, has worked a lot in the United States with immigrants, refugees, and other cultural groups, and also has done a lot of work internationally. She's worked with Doctors Without Borders, the Center for Victims of Torture, and Solace World internationally. She's also helped as a consultant in setting up a mental health system in Liberia. She also provides expert testimony in the areas of immigration, post-traumatic stress disorder, and child abuse. So, with that,
Thank you.
Dr. Mitchell.
It's quite a pleasure to have Dr. Sabin introduce me. I was telling Molly that he's a bit of a national celebrity, and when I started getting into this field domestically, I was attending conferences, and whenever I'd say I'm from Denver, they'd say, "Do you know Dan Sabin?" So I appreciate the time you took to join us. So thank you for coming today, kind of midday and over lunch hour to boot. It's a pleasure to be here. I've had the chance to collaborate with the Center for Global Health a number of times. I was recently invited by Dr. Sabin to help out in presenting with pediatricians who were looking at disaster response, and it was a pleasure. And I was telling Dan, it's an exciting time to be involved in mental health. I've been in this, especially global mental health, I've been in the field for about a decade and a half, and early on it was a fight to get a spot at the table, and why is it valuable, and there was always this pushback with Maslow's hierarchy of needs, like it's too soon, it's a luxury, we're not going to talk about that yet. But in recent years, it's there's an acknowledgement that this concept of there's no health without mental health, and that mental health is getting in the way systemically, both domestically and internationally. I've worked in the ER here for a number of years between missions and seeing a beautiful setup that's worked in other states with better psychiatric availability of beds and things like that, and how much our system kind of gets impacted by individuals and patients with comorbid or in freestanding psychiatric needs. So it's a pleasure to be here. Very quickly, everyone's doing some international work or interested? Yeah, okay. What kind of areas have you been working in? I know Guatemala is a big spot for CU. Are there other regions just to keep on my radar?
Nepal.
Africa, Nepal, great. There's great research coming out of Nepal. Haiti? Okay, great. Well, great. Any point along the way, please don't hesitate to stop me, interrupt, ask questions. I actually only put a few slides together to kind of anchor the discussion, but what I discovered the last time I was here, that there was this deep curiosity of how do we do culturally competent care with our refugee patients here? How do we ask about mental health issue in a sensitive way, or in a way that makes sense of the way their local idioms of distress, right? The way they would express it, rather than our assumption of, do you suffer from major depression more days than not for the last few weeks, right? That's a trick. Navigating that is something you have to be really mindful about. So this first picture here was my first deployment or mission with Medicine Without Frontiers, or Doctors Without Borders, and I was on the tail end of internship to become a clinical psychologist out in New York, and was sitting in a grand rounds, and a gentleman came around and said, "Hey, I just got back from China with Doctors Without Borders," and I slowly raised my hand. I was tracked to become a forensic psychologist. I was working in at the long-term psychiatric hospital from Bellevue on a not guilty by reason of insanity unit. I didn't have any global mental health, was not on my radar. And I raised my hand and said, "Do they take psychologists?" And again, well over a decade ago, they said, we just started thinking about it. And Dan, that was about the time I think Dan pivoted as well. And I ended up putting my stuff in storage in the Bronx and jumping on a plane. And my first deployment was to northern Nigeria. And you'll see that the contrast pictures, there was a very significant, religiously motivated Some of it was about land rights, conflict that lasted a number of months. Hundreds were killed, and mostly it was tension between a Christian minority and a Muslim majority. And I got off the plane. I was picked up within hours of heading north. We're passing, mass graves, and I'm being briefed on what's happening. And I can kind of comfortably say I wasn't ready for a lot of it. I came back and I needed to get a lot of support myself, and I actually feel very passionate about vicarious trauma interventions and staff welfare as a result. But I arrived, and I was part of a health team. There was a cholera outbreak. There was a pediatric surgeon helping with some surgical needs. There was a huge logistical team doing rebuilding latrine work. And I was the kind of odd man out, which is probably what psychiatry and psychologists felt like decades ago, trying to, how do we help with it? Like, what do you need from me? And there was a recognition, especially from the local docs and nurses, patients are showing up with stomachache, headache, backache. There's no etiological reason for it. It seems stress-related. We think they're having trauma reactions. We're handing out paracetamol and other placebos just to try to calm people's nerves, but we need help. So we launched, and I was handed a team that rode with us from the town that we stayed in, which was slightly more stable, to the town where we were serving our beneficiaries, and the staff that they had hired to help with mental health would ride with us. And it took months for me to figure out that because of where the base camp was, that all the hiring had been done in the Christian village, and we were all driving together into the Muslim community to provide services. Many were useful and helpful, and they was really well trained, but when it came to mental health, I quickly realized that to create a really safe space for our beneficiaries, that we needed to have local staff. Now we call this, kind of lay counselors or task sharing that represented the community that was being served, that could really understand what happened. So we hired an equivalent amount locally, which was really helpful. And we, in the training up of our local counselors, did a lot of, essentially felt like peace building work around the conflict and how to create safe space when you had difference of opinion. And they ended up becoming fast friends. I called them, originally we had 5, I called them my Fab 5. And then we had to hire another because the demand kept going up and up. And so we were running upwards of 30 groups a month on an 8-week cycle. And in the bottom, when we built out the clinic, the weight was so significant. We were trying to build places for shade, and our counselors would conduct dramas to try to capture some things that were mental health related as a way to kind of normalize abnormal experiences as it relates to stress responses. So they would do dramas on what might look like depression in their community, disassociation, capturing things like domestic violence, and then offering service provision. And it ended up working really well, rather than kind of taking in our, this fear was always, are we just going to outsource our psychiatric understanding of disorders to the rest of the world? There's a great book done by a journalist, Ethan Waters, about Crazy Like Us. Are we just globalizing our concept of mental health? And it's really important not to do that. And global mental health has made a lot of progress in how to do that, and partnering with cultural anthropologists and things like that to really understand local idioms. So as we continue, Dan, thank you for the introduction. I didn't know I was going to get that. So again, my name's Gwen. I'm over at DU. We have this master's program embedded in our PsyD, which is the flagship that is an international disaster psych. So it's a clinical foundation. They're geared up to graduate to get licensed domestically. So there's a lockstep of courses for that. And then the first summer in the program, we're in now 12 different countries around the world, partnering with local and international NGOs in terms of mental health projects. Salus World is an NGO that I help with international services, and we have a project going in Myanmar and Grenada. And we do a very similar thing, a partnership with the hopes of sustainability, rather than dropping in and providing 4 walls treatment for a short period of time, really building up capacity locally and providing supervision, which the newest kind of wave of understanding global mental health is the ongoing supervision is essential. We, for a very long time, would go in and kind of do intensive trainings and encourage lay counselors to kind of continue the work, but without the supervision and support around systemic needs and organizational needs and just ongoing supervision on different types of cases, the programs tend to fall apart. So we've now been in Myanmar for about over 10 years. We have a country director who provides supervision, and I help and provide remote training and supervision for that project. Other things I've done to help anchor, or if people want to talk about them, some were mentioned, some of the organizations I've consulted with. The two in the middle are the ones I feel most proud about. Fortune Mental Health on the top and Heal the World are locally registered, established mental health NGOs in Myanmar and on the Thai-Burma border. And so they're there, they're providing direct service, they're doing a lot of advocacy work, learning from liberation psychology that sometimes working on social justice issues is a way to help with mental health. So some are doing advocacy for identification rights and registration and things like that, but all having a mental health component. We're going to pivot into the needs. So the scope of the problem is noteworthy, and I don't want to just swim in stats and send you on your way, but it's important to kind of think about what we're looking at. 50% of people don't receive care, appropriate care for mental health disorders, and even in developing countries, the treatment gap, as we go to low and middle income, it skyrockets to 90%. Many countries, there's one psychiatrist. There's one psychiatrist in Liberia. There used to be one psychiatrist in Ethiopia. He was recently put in prison. So other places we're looking at under 10 to 100,000. Incredible needs. And we need to think creatively about how to fill those gaps. Other quick stats so we can kind of ground ourselves. More than 450 million across the globe suffer from mental illnesses. By 2030, depression will be the second highest cause of disease burden in middle-income countries and the third highest in low-income countries. So when the WHO and when health and public health started thinking about DALYs, which is this disability-adjusted life years, all of a sudden when mental health was included, and they're actually not even including suicide, it was remarkable how much mental health issues were really impacting quality of life, functioning, things like that. In the U.S., people with severe mental illness die 25 years earlier than the general population. And then suicide. One of my classes this quarter, and something I feel deeply passionate about, is crisis intervention in suicide. And it's a pandemic nobody's talking about. There are 1 million suicides a year globally. One person every 40 seconds on this, when you think about the global rates. And it's increasing worldwide. There's been a lot of awareness raising within the veteran community and other vulnerable communities domestically, but it's rare that people kind of think globally about this significant issue. More than 90% of people who commit suicide have a diagnosable mental health issue, so it's a really important thing to think about. And then among the three leading causes of death of those aged 15 to 44 in some countries, and the second causing for the slightly younger age range. So pretty significant. So today, again, 80% of people experience an episode of mental disorder in their lifetime. We're really going to pivot to low and middle income. There's big needs here too, undoubtedly, especially in Colorado. We're ranked pretty low with regards to psychiatric inpatient services. We're sadly, a lot of people ask why this program that I teach, International Disaster Psychology, it's a very unique program. We recently got an award, but why is it in Colorado? And sadly, Colorado has a legacy of being somewhat of an epicenter for some disasters. We have a lot of students with the Colorado State Office of Public Health doing disaster response, but between Columbine and the Aurora Theater shooting and fires and floods, there's a lot of needs here as well. The second big impact statement, and I think if anything, global mental health is getting better about how to talk cross-discipline in a collaborative way, and we've realized if we talk about the economic burden, that more and more people are getting interested. The title of my talk was called Coming Out of the Shadows, and that's actually borrowed from a collaborative roundtable between the WHO and the World Bank. And the World Bank and the World Economic Forum are kind of standing up tall saying, we have to fight mental health issues because it's getting in the way of economic development, right? And specifically the World Economic Forum had noticed that in the second kind of what we call middle income, a lot of the blocks from moving from middle income to higher income have to do with mental health. That it's the disease burden, this disability piece, was really impacting economic output, sustaining job attrition, things like that. And I actually had anecdotally, at the time I started hearing about this, I had a friend call me from a good friend that I had trained with from years from Uganda, and he said, Gwen, me and my wife, we've never been more economically stable. We both have cell phones, we have a car, we both have jobs, and I've never been so depressed in my life. And it's kind of that feeling of like, welcome to the developing world, where change and activity, even good, can cause stress, and that we need to honor that. And in development projects, I often talk about even successful development projects that have nothing to do with health or mental health. For example, microcredit or microfinance, loans and things like that. That there's been these tragic narratives around group suicides of women who haven't been able to pay back their loans, or noteworthy increases in domestic violence when loans are only being given to women in communities where men used to kind of hold that power of the pocketbook. And while there's other ways to do empowerment and intervention programs around that, it's important to know that even good stress can lead to mental health strain, right? Anxiety and depression, prevalent. But defining them is really important. And again, why the global health movement, why it's exciting, is this partnership with cultural anthropology in terms of methodology of what are we looking at in terms of what psychiatric illnesses we're seeing, and how do we test it, and how do we see if our interventions are working. There's some really exciting method development around that, and there's a woman, a cultural anthropologist named Bonnie Kessler, who's been doing some amazing work in Haiti, and she's found by some instrument development that what we define as depression here in the West actually doesn't exist in Haiti in the same way, and that their version of depression is actually this kind of hybrid of depression and anxiety. And so a common idiom globally, but specifically in Haiti, is this idea of thinking too much. I can't stop thinking. And being able to ask that and knowing it's yoked with depression is really important, because then there's ways to do interventions. And kind of understanding these idioms is really important. So anxiety and depression being an important point. The last pivot we're going to do is talking about funding. One excited reason when Molly asked me to come was mental health standalone projects are really hard to get funded. Even with Salus World, we are famous for being finalists in the funding pool, and their feedback is like, this is one of the most innovative projects we've ever heard of, super important, but we're going to go with building schools. We're going to go with building roads. That there's always this we have other priorities that would have a much more photographic impact of sorts, and standalone mental health is tricky. Collaborative, cooking mental health into health projects, cooking mental health into, Watson projects. I had this fantasy that one year I would only go to conferences that had nothing to do with mental health and talk to Watson experts about where you put your latrines affects the sexual assault rates for these girls in these villages, or how you build your wells. If they can't pump the well and they have to get help for that, then there's a risk for exploitation. And so really thinking cross projects in terms of funding, as well as some other creative things that the bigger entities kind of top down are doing in terms of taxes and other things like that. And then the return on investment, kind of scaling up great returns, improving health, improving economic performance. Okay, it's not going. Okay, global burden of disease. I've mentioned it. I'm just going to kind of go quickly just to hit that home. It's no secret that mental disorders cause untold human suffering. Like if we put diagnostic categories aside and think about grief and loss, being displaced, being separated, losing kind of cultural practices, a lot of lessons learned out of Liberia during Ebola, and they're significant, and they can epigenetically be passed on, trauma and PTSD. We're learning all this stuff about this, and that it's important to think about how much mental health is impacting health. 30% of non-fatal disease burden worldwide is mental health. And in India, suicide, mentioned earlier, has overtaken complications from pregnancy and childbirth as a leading cause among death in women aged 15 to 49. So significant and, tricky questions to ask about, because even, our standard questions, have you ever gone to sleep at night and hope you didn't wake up, don't always work. I remember a colleague who did a lot of work in Peru, and her kind of classic depression questions around, like, how long do you sleep? Is it hard to get up in the morning? That must be some sort of luxury you have up in America, to not get up and go to work in the shoe factory. And I'm really depressed, but there's no way I'm staying in bed all day. I have four kids to feed, but here's my problem. I can't concentrate. My fuse is really short with my children. I'm in a violent relationship, and I'm worried how that's affecting my children. So really kind of understanding impact are often different questions. So two main reasons to think about it. Money. The economic output caused by untreated mental disorders reduces rates of labor, taxes, kind of pitching it to someone who says, I don't care about mental health. You can kind of talk about it in different ways. There is more than 10 billion days of lost work annually from mental health issues, the equivalent of $1 trillion a year. So it's significant. And then this two-way connection, and again, this audience, why it feels so important, between mental health and health. Things like poor diet, things like, limited physical activity, we know causes problems cardiovascularly, cancer, obesity, diabetes, and that these things, if we can help mental health, which is usually, penny on the dollar, a little bit cheaper than trying to get, a cold storage transfer of medications that have to be kept in a refrigerator from the capital to the interior. If we can help with mental health, penny on the dollar, it can improve health outcomes as well. Also, and finally, excitingly, the Sustainable Development Goals, which replace the Millennium Development Goals, does endorse and talk about mental health, kind of finally. And that their goal, promoting mental health and well-being and reducing mortality for non-communicable diseases by 1/3 by 2030. So it's there, and it's cooked in, which is really exciting. A couple years ago, I was on a panel for kind of success story reflections on the Millennium Development Goals, which are noteworthy, and a lot of incredible work has been done. But with each goal, maternal health, education, human rights, there's a piece to say, mental health could help you with this. We actually could get better at outreach, advocacy, stigma reduction. We've learned a lot about stigma reduction in the global mental health field that historically we thought, awareness campaigns or commercials or billboards were the way to go. If we just get the word out there, it will help. And actually it's been found that there's a pretty limited impact on reducing stigma in that way. And what it takes is an encounter experience of someone with lived experience. And then why the peer support movement is so significant, both here and abroad. And meeting someone else who struggled with a similar thing is really the most impactful. Or seeing someone with bipolar disorder have a job and have a family and be the pastor of a church. There's this fabulous pastor in Liberia who struggles with pretty significant psychotic episodes when manic, and was told by a traditional healer, I think your uncle might have cursed you. You probably need to kill him to get, to keep yourself safe from this episode. And he decided, I don't think that's the reason. And he went and saw a mental health provider, and he got on medication, and thank God, kind of a positive outcome. There's also space, though, however, to collaborate with traditional healers in really thoughtful ways, which is exciting. So a quick story to kind of humanize it. I'm going to, in this Nigeria, we did some exit interviews and pre-post tests in terms of participation in the groups. And I want to share one woman's exit interview. Last year, I was having terrible head and body aches due to a cold and was experiencing heaviness in my head, which meant I couldn't sleep. Sometimes I would just walk, and at first people just thought that was me being a typical Hausa. But I found that sometimes I didn't know where I would end up. I did not feel like eating food, and I had no interest in completing my daily household chores. I was worried about my daughter, and I had to help her end a marriage because her husband was not treating her properly. But because of the recent conflict, everyone thought it was better to leave it alone. They didn't want it to cause shame for our community. This issue caused frequent fights and arguments with my husband and son. I began getting disturbing thoughts and had no interest in doing anything. I thought that my existence was not worth it and wanted to end my life. I even bought some pesticides in the market. I went to the clinic where I watched your counselors do a drama, and I thought, it's like they came to my house and looked in my window. I asked for help. Alwal offered me a counseling in a group. I can't explain how much it helped me. Alwal helped me understand my health problems in an easy manner, and the women in the group helped me see I was not alone. After just listening and trusting, I realized my disturbing thoughts had reduced, and I wasn't walking around in a spell anymore. I don't have thoughts of ending my life. I've started doing household work again, and I also go to mosque for worshiping and go to the market every day, every Saturday, where I spend happy time with my daughter, and sometimes I see and smile when I see women from the group. Alwa also told me to start interacting with my neighbors more and start talking to my husband more often without being angry or sad. I feel good these days, which makes me happy, and we talk more about what we can do for our daughter. It's a case study. So the 4 key kind of out of the shadow WHO global mental health movement points. First is making the case for investing in global mental health, which I've already mentioned a lot about, the connection between health and well-being and mental health. And then the economic kind of case is there as well. And in 2010, the global cost of mental disorders was estimated to be approximately $2.5 trillion. By 2030, that figure is projected to go up by 240%. 54% of that burden was borne by low and middle income countries, also projected to reach 58% by 2030. 2/3 of these costs are indirect ones associated with the loss of productivity and income due to disability or death. So the first one, there's a case for this. It's not just a bunch of mental health people saying, like, we need people to feel better. It's much more significant. The second thing, dealing with common mental health disorders. What's also exciting in the global health movement is that there are some large-scale studies being done on, can we do this soundly, with impact, in a culturally competent way? And the conference that I mentioned that I went to with Dan, psychiatry was actually ahead of the curve, getting involved. A lot of psychiatrists are doing incredible stuff. Vikram Patel out of the London School of Medicine, who's based in India. Brandon Cohort does amazing, has great literature on Nepal. His sister now works in our program, which I'm delighted about. And she does incredible work in Peru. There's a gentleman named, there's a number of people out of Johns Hopkins that are doing large-scale, multi-village, kind of looking at how do we do this and do it well at a reasonable cost. And then the treatment pivot, like learning how to adjust treatment in a culturally competent way. There's a lot of culturally adapted cognitive behavioral therapy interventions. I'm excited about this new horizon, maybe a second wave of including relational kind of theories around when we recognize a collectivist culture and the strain that mental health issues and other things can cause on a community, how to integrate kind of relational work into it, which is really exciting. Drug therapies are becoming more and more available thanks to WHO's mandate of including psychiatric drugs on formularies. They're not always available, and a lot are kind of generation 1, which have a lot more side effect profiles and other things like that, but they're becoming more and more available, including SSRIs and other things like that. And then thinking about other systems that are good places to intervene. School-based interventions, community-based interventions where teachers know their kiddos. And we worked with a lot of teachers in Nigeria on this project, and they would say, this kid was so clever before the conflict. Now he's so aggressive in class, and I can't get him to sit still, and he's always breaking things, and then the referral comes in, come to find out, dad was killed, mom was killed, he witnessed a horrific killing on the soccer field or the football field, doesn't want to go out and play soccer, and all these things that had a trauma kind of base to it, and kind of really working around what behavioral problems can be tied to mental health struggles, right? So number 3, the resource gaps. This can be, for a long time, all well and good, Gwen, but where are we going to get the funding? And there are, arguments, again, for this penny on the dollar, as well as just looking at kind of per capita costs. So they say that annually it's about $2 per head in low-income countries to be able to offer sound mental health treatment. So it's not so significant that maybe we can't do it. When you move up lower to middle, it's $3 to $4. Latin America and the Caribbean, it's $7 to $9. So on average, this corresponds to a 10 to 14% increase in public expenditures. But global mental health or health budgets, it tends to be less than 1% that's given to mental health efforts. So that has to be increased pretty significantly. Thinking about potential funding, WHO has thought about. They have some great literature on kind of the example of in crisis. Sometimes there's good outcomes. So they use examples like Afghanistan and Iraq and other places where significant infrastructure was ruined, but in the build back, mental health was included. Community mental health centers, psychiatric inpatient units. So it's actually more accessible now than it was pre-conflict. While, of course, there's other things going on, it's there. Some argue for kind of sin taxes, which is the idea of including more tax on alcohol, drugs, cigarettes, that could help and that could feed into mental health funding. Others talk about kind of mineral wealth and having taxes tied to that, and there's some countries that have some good outcomes with that. Cuba, Chile, Colombia. Cuba, just like with mental health, they're kind of ahead of the curve, and they do great capacity building as well. They invite students from other Latin American and Caribbean countries. They train them up for free with the promise to go back and provide services in their home countries. Which is working really well. So thinking about capacity building is probably next on the horizon, but really thinking about how do we pay for this. The other piece is kind of embedding mental health in other calls. It was my idea that mental health standalone is still having a hard time getting funding, but mental health cooked into a World Bank proposal on economic development, it seems to have some traction now. There's kind of where the wheels are meeting the road, and really thinking about collaborative and as thoughtful. If we do this project, will there be a mental health impact? Could we offer support? So some of the microcredit, a lot of the HIV projects, but microcredit specifically, let us have support groups around how is your business going? Can we support you on making plans? How is your family life? Do you need family interventions? And so offering support in that way. And then finally, the key policy actions. I don't have that page, but one is that, mental health matters. We have to get through this stigma or this assumption that it's a luxury of the West. I'm often asked, Gwen, how do you go and work in refugee camps and then come back and have a practice here? Like, aren't you a little bit annoyed with the worried well, or how do you have empathy? And my answer often is, no one has the market on trauma or domestic issues, or the work I do here is as intense often as I do in the camps. And it shouldn't be an either or. We shouldn't live in a world of dichotomies where we make a decision to only work globally and not domestically. And with current executive orders in the air, there's needs for refugees and other things that are pretty significant. So work domestically and abroad. So mental health matters. I had one trainee in Burma who was really resistant, and there was a piece of, he acknowledged, like, I have a lot of stigma with this. And by the time we got through a year of working together, and he now works for the BBC, he came out to his family, he got support, he's a leading activist in the LGBT community in the country. His statement is, everybody has mental health, and we shouldn't feel ashamed of this, and we all need to help each other, and kind of really reducing stigma is a big thing. And then mental health collaboration, kind of that policy action, which I've advocated for around how do we do this in such a way where it's not decreasing any one sector. There was a big talk years ago around these, what they call clusters. In the UN community, there's a health cluster, there's an education cluster, there's a security cluster, and there was this push for a mental health cluster, which is important in terms of kind of being recognized with the big boys, and like we're as important as any other cluster. But there's been a shift, and the thinking is, let's infiltrate all of them. We don't need a standalone, let's get inside. So really thinking about key policy actions, advocacy, and doing it in a culturally competent way. So another quote from a group member, it's like magic. Somehow this group allowed me to find hope again, and I learned to take care of myself. I had no idea how bad I was until I compared myself to how I was doing before. And I know now that I didn't need a pill for what was troubling me. So again, being able to avoid just psychotropic interventions, knowing that sometimes it helps, undoubtedly, but sometimes the side effects of psychotropics lead to other issues, diabetes, significant weight gain, other things that can be troubling and cause other health outcomes, and really thinking about, is there a therapeutic intervention that could help curb the stress and distress that's going on. So I have a lot more examples. I could do country specific, but I actually wanted to make sure I gave us enough time to check in and ask questions or dialogue about what we see in terms of mental health or why you decided to come today. And we can kind of open it up from there. Any questions? Yeah.
How much of global mental health right now is crisis-driven? I mean, I know there was an influx in Nepal right after the earthquake.
Right.
And now it seems to have retreated.
It's a good question. I mean, there's definitely been a professionalizing of global mental health, which in the service of kind of preventing the parachuting consultant who wants to do well, but maybe it's not in the most sustainable way. I mean, and it happens here too. Post Katrina, it happens everywhere. But as the field professionalizes, there's some resistance to that, and the kind of the core community would say like that shouldn't be happening as much. But sometimes it's driven by resources, and that in those first months, days, there's money, but it's not always the ideal time to do the interventions, right? I remember after the Haitian earthquake, a lot of people, when are you going to Haiti, going to Haiti? I'm like, ask me in 2 years. That's when I think I should go, because by then nobody will be talking about it, and that's right about the time we should open up pretty significant trauma work. And so I would argue you're probably right. A lot of that might be independent donor-driven, like a willingness to do it on someone's own dollar, or having faith-based related funding. The bigger macro systems are not driven by that as much, and they're really thoughtful about accepting proposals that are much more, how is this sustainable? How do we keep the skills in the country? And so today there continues to be some great work in Nepal. And this Brandon cohort that I just mentioned, he got money from Duke. He brought 2 clinicians to Duke to do some intensive workshops, and they actually got a faculty line item. So they're staying another year, but doing biannual trips back and plan to go back. So this piece around how systems can collaborate and education efforts, I think, is the new horizon. Harvard's doing some interesting stuff. Johns Hopkins, I'm excited, DU, we just partnered with Tubman University, which is in southern Liberia, to build an applied psychology certificate program for all of these. Because sometimes post-disaster, there's a ton of locals who've worked for like 15 different NGOs. They have binders this big with like 2-day, 5-day, 2-week certificates. I did a PTSD training. I did a basic mental health. I did the MH gap. They have all these binders, but collaboratively, these NGO certificates don't mean anything anymore because a lot of the NGOs have phased out. And so professionalizing that for the context and partnering with universities and giving them a degree seems really important, because sometimes where there's a lot of stigma, there's medical docs who turn to these lay counselors or trainers and say, who are you to be training me right now? I'm a doctor, and you're just a mental health counselor that was trained by NGOs. So there's some thoughtful ways to think about sustainability, which I think is so important. Did I answer your question though? Okay.
In regard to that question, I've worked with a small rural development project in Haiti, and a lot of the work we do is responding to their requests and needs that they identify. And the only time they ever brought up anything about mental health was right after the earthquake.
Right.
And I wonder if in a culture like that, it's a lot more socially acceptable to recognize that people have mental health issues and mental health needs than it is in a situation that is not so much, tied to a crisis. And so people might be more willing to ask for mental health and to recognize the need in their communities.
During crisis.
Right.
Because there's a stressor.
Yeah.
Yeah.
And because so many people have mental health issues.
Right.
And so it's not so much a, just somebody else's problem.
Right. Which, you're probably right. Like, there's a moment where stigma is reduced. What we have to be careful about, though, is kind of the gold standard for mental health crisis response right now is what we call psychological first aid. And they're first and foremost, they say we need to acknowledge that 2/3 of everyone who shows signs of distress recover without any intervention. That there's, I'm not doing well, I'm not sleeping, and I'm yelling at and then there's a recovery price, especially with collective trauma, because there's a community healing that happens as well. And so not intervening too early, not diagnosing too early is really important. So honoring that process. But I think what you're also saying is there a chance to talk about it when it's not as stigmatized? There's almost a window to say, this is really stressful. Let's talk about all the things ways that we can emotionally, or sometimes when I'm in the field, no one knows what a psychologist was. Even when I showed up in Burma the month before, and I don't know if you remember this from the news, there was a gentleman with Tipple from Tennessee who went to Burma, swam the river the pond that surrounded the Aung San Suu Kyi's home to save her. His delusion was, I was meant to go to Burma and save this princess from house arrest. And so when I would show up, I'm like, yeah, I'm a psychologist. They're like that guy from Tennessee? Is that, and having no other anchor. And so I often talk about kind of being a doctor of the heart and the mind, and that a lot of idioms of distress culturally, they talk about, my heart's in my throat, or my heart's sunk, or it's beating too fast, or I'm thinking too much, and I don't need to break out the MH gap and say, well, this is what we decide is depression. But I think you're right about opportunity.
I think the intervention that was done was with the help of Mercy Corps, which had mainly been working in Port-au-Prince, but there were so many traumatized people who had moved out to the countryside to receive support from their families of origin. So we brought Mercy Corps people out there, and they were mainly working with the communities about kind of reinforcing their usual pillars of support.
Right.
They weren't making diagnoses.
Yeah.
But I think they were just helping to facilitate this process of community recovery that you were seeing tends to happen.
Great. The other group that's doing really great work in Haiti is Partners in Health. So Paul Farmer's initiative. What they do so fabulously, which makes everyone envious, is they decide to intervene in a country and then they get 10 to 15 years of funding, right? Which is unknown in the world of NGOs, especially looking for mental health. Our Miramar project has been funded by Open Society Foundation for now since 2008, but every year we have to, submit a request for proposal. There's a 6-month break, and then the proposal, so they and by extension, Ms. Bonnie Kessler, have really great research on mental health in Haiti, so I would recommend them. I'm happy to share resources too. Other questions or reflections on mental health? And Dan, please, if you have examples as well. Yeah.
To know more, you mentioned we work in the HIV program at Children's, and I work with pediatric populations, and we've seen a large increase in the number of international adoptees, and obviously there's lots of trauma among them, and as well as refugees in our program. Can you address any HIV specific?
Yeah. The HIV world was ahead of the curve in terms of integrating mental health earlier on, and some of it was adherence and compliance counseling and other things, and integrating peer support, which was a big help for compliance, especially with the fear of if we're non-compliant, we're messing with strains and things like this. So there's some nice models in terms of the health interventions, but I think your question is more subtle in terms of how do we talk about this with the kiddos and cross-culturally, and I think this deep, humble curiosity of what do they understand now? How does, in their country of origin, how is this explained? And kind of working with myth busting and other things. Folks are definitely hungry for knowledge, and I think historically mental health folk have been, I don't want to bring something here that doesn't feel like a good fit, but I think what I've learned with most of my collaborating partners has been tell us everything you know and we'll tell you what might work here. And so getting that understanding of what are current practices, things like that. And I just think, really understanding, what else might be traumatic about diagnosis in terms of, is this that I have a cursed past life? Is this about spells? There might be other kind of explanatory models that exist for individuals with different diseases that are probably important to understand so that you can help with treatment planning that honors that or loops in community members to support in new and unique ways.
Yeah. I think in our program we've struggled. We have a lot of African women
Mm-hmm.
that come, and we see pregnant women as well, and I think that's an area we've really struggled because it's great to get them all together to get support, but none of them will come.
Yeah. Are there
Because
navigators?
there's
Do you
fear
have like navigators that?
we do work with Project Shine. So that's worked with some that if we have an event that's specific and they're worried that they'll see another person from their community, they won't show up.
Yeah.
And they can't get the support that we're hoping they'll get. And so there's not only the stigma of HIV, there's the stigma of mental health.
Yeah.
There's just so much that we're working with to try to support
You know,
them.
some of the mental health groups, there's a gentleman, Stein, out of Chicago, who did some Bosnian support groups for trauma survivors almost a decade ago. But his outcome measure, he didn't want to do any mental health outcome. His outcome measure was pre and post, how much do you go see your primary health care provider? And post, there was more compliance to appointments and more asking for help. So that idea of, is there a way to develop a support group for them, or utilizing these kind of cultural brokers, a navigator who can kind of navigate both worlds and help people not only with interpreting but kind of understanding, because what we understand about successful integration when it comes to refugees and resettlement here is that social bridging and kind of feeling like this has become home, that statement is an indicator of oftentimes employability, retained, lack of attrition with employability, feeling like, there's these great questions of like, if I were to drop my wallet today near my compound where I live, I know it would be returned to me. And so some of that's community within the refugee community they're with, and some of it's cross. So that receiving community having HIV positive women, from the United States navigate and kind of work and offer support, which can, these social bridging activities are, when it's cross-cultural, are just some indications that they're helpful. But can be hard,
I have a question about kind of patient navigators and cultural proficiency and how you navigate language barriers here and abroad.
Yeah. It's not easy, right? It's especially with psychology, because it's a word-based, right? Like everyone's like, how did you do that? And I remember in our Thailand project, at one training I did, I had triple translation in terms of Korean, Burmese, Sean, and then it kind of looping back. And my fear was like, is this some terrible game of telephone? And we don't know like what's happening. So it is the hardest, most exhausting part. And it should be recognized for both sides. And so there's a shared experience in that can be used as building rapport. Through the IDP program, we have a trauma disaster recovery clinic, and we're serving a lot of refugees and immigrants and other transnationals. And, I'll have students be like, I tried to call her 6 times and the Medicaid interpreter didn't show up, and I think we should just give up. And like month 2, still trying to make contact. Month 3, we now have a number of home-based care, one being a recommendation per Dr. Sabin, where can we come to you? Would that help? And so kind of doing with a Iraqi woman, a Moroccan woman, and kind of going into the home. And now these moments of our students just learning how to say hello and how are you in French and Arabic is like the most healing experience for some of these clients, but it's exhausting. And I know working in the ER, the interpreter phone lines, you can't hear them, and there's like 15 people in the waiting room, and just to sit with someone and say, like, this is going to feel really hard from both sides. My hope is to understand you the best I can. So there's this added need for rapport building, but the payoff, once you get through some of that, it's never easy. It's like your head's hurting because you're also in the space of, I don't know if I'm understanding this rightly, and great interpreters. One of my examples in Nigeria is I was interviewing this gentleman, and everything about it fell off, and he would speak, and then the interpreter, thank God he was trained with mental health, eventually would kind of sit there, and he would say these long statements, and he'd sit there and he'd think, and he'd say, the mister is hungry, and then it'd turn, and he'd talk, and then he'd turn and be like, and he's concerned about the weather. And then I was like, wait, okay, what's happening here? And he's like, what he says doesn't make sense. And I'm like, is it a different dialect? What is going on? And the guy was fluidly psychotic. And he was trying to help me understand someone who was talking about butterflies and eating ants and these things that didn't make, he didn't want to just interpret. So a lot of it is the interpreter training, which is hard, and there's never time on the job to do that. But sometimes pulling, it seems like west of the Mississippi, if a Myanmar native gets in trouble for a felony, either murder or some pretty significant case, I'll get a call from an attorney that says, I hear you're a psychologist who understands trauma and the context of murder. So I've been to Kansas and up to Vail and these random arrests that sometimes are about mental health, sometimes they're not. And before going in to do these interviews, kind of sitting with the interpreter and being like, okay, first of all, this is going to maybe feel like a different interview because of mental health. Can we build a little bit of a rapport so that what happens in this triad, but sometimes there's not time for that. I think the idea is kind of patience and recognizing a mantra, my effort here is actually therapeutic. Because most of their encounters are, what do you want? I can't understand you, get out of my store. Or go home because I don't like your hijab. Or, and you're sitting there and really trying is actually pretty therapeutic. I know it's still exhausting, and I hope it's not. If anyone has any other great answers to that, yeah.
I think a classic demonstration of the difficulty to translate some tools. Somebody says, "Have you felt blue for more than?"
Right.
Well, let's see. I don't think so. It's really weird phrases that we try to translate. I wanted to ask about. You mentioned something about the microcredit women suicides.
Yeah.
I have heard about male farmers in India, for example, committing suicide, but I've never heard it associated with microcredit, which could be my ignorance, or it doesn't show up on Google.
Yeah, it's pretty anecdotal, but there are a couple published studies, and then there are the kind of just narrative. So it's not an epidemic of any sort, but there's something to just recognize, we don't like being in debt here either. We actually, the number one, adult Caucasian males, and they're between 40 and 60, remain to be our highest band of completed suicides in America, and often tied to financial distress. So on a stress indication, it makes sense. And it's not by any means a talk against microcredit, but more of how do we help them deal with the stress of this piece? Another great example of that, if you feel blue, we often use Likert Scales, right? On a scale of 1 to 10, what's your pain? Or on a scale, Likert Scales cross-culturally are what? And so there was this movement to draw pictures of a cup that's a little bit full, half full, and then there was the next iteration was someone carrying a small load on their head, a bigger load on their head. And in Haiti, actually, they were doing focus groups about the measurement scales, which is so important. This little boy said, flip the scale on its head, and he said, if my mom saw me bring home that much water, she would beat me. So that the lower amount was actually the most stressful, because if he didn't bring home as much water as possible. So, we have to be really careful about assessment, because junk in, junk out, right? From an assessment perspective, but understanding in some of these focus groups and taking the results back to the community. My colleague who took some results back in Peru, the healing piece was about parenting practices and these women who at face value looked and appeared very depressed, and they in many ways had symptoms that met criteria for depression, but there was these life issues that were causing a lot more of the stress. And by having feedback around that, they were able to connect. And she described this circle of when they were giving the research feedback, where a woman said where she was from when they migrated to work at the shoe factories, and a woman who she had known for 8 years sitting next to her said, well, I'm from there too. And and kind of connecting during a research feedback session. So really thinking thoughtfully about that. Yeah. Any other questions or comments? Was there something you hoped I was going to cover today and I just missed it?
Does your work in Myanmar in the conflict zones?
Our country director has been going up to, he's done a little work in Bangladesh and in the Rakhine area, which is some people call this a slow-burning genocide.
Right.
And has done some work up there. And there are some Rohingya that are getting resettled here. And there's the resettlement agencies they find them as a kind of a very difficult community to serve because they're not showing up for appointments and things like that. We had a We have some refugee adjustment groups. We were able to get one Rakhine group going, and the level of complex trauma and the level of, kind of a paranoid disposition about providers was so significant, and such like a wonderful way to feed the refugee resettlement agency back information about, like, they're not just difficult. 'Cause sometimes single Congolese women get a bad rap, and like, well, let's talk about their trauma narratives. Let's talk about their stress and the lack of support in their households, and they're all living very independently. So kind of understanding trauma narrative, not to kind of put them in a box of like symptoms, but to maybe help understand other difficulties in providing services is helpful. But it's significant. In our other main projects where we have some good outcomes for a support group, one of the interesting outcomes was in women reporting better menstrual cycles after attending our group. So again, that kind of mental health connection. But we serve vulnerable communities in and around Yangon, which includes the LGBT community, commercial sex workers, drug users, and then vulnerable children and orphans, and kind of disabilities of different ways, but offering a support group in that way. So a little.
You mentioned there was work being done in Grenada.
Yes. So Grenada has been more recent. I was approached by a great group out of New York called Reach Within, and their story was a gentleman who had a long history of working with elder care facilities in the States, met and began collaborating with the Grenadian National domestically, but he said, we need this, we need to help our elderly in Grenada too. And so about 10 years ago, he started going down to offer, to start thinking about how they could better serve their elderly, which is often a very underserved community that people don't always identify or think about, and often because they're home and they're not as mobile. When the recent elections in Myanmar, there were elderly were on the street who said they hadn't left their house in years but had to come out to vote and things like that. But he started this project, and then tragically had a heart attack and died on the island. And his family built up a foundation and then has since been doing incredible work on the island. And Grenada is a very interesting place. I went there thinking, I've been to Jordan, I worked with Iraqi, I was in Liberia, like this is going to feel like a cakewalk. And it's complex, it's much more complicated. Grenada, the historical trauma, the legacy of the kind of the slave trade, there's no indigenous left on the island. There is horrific rates of domestic violence and incest, tragically. So there's a lot of care homes for young girls who are having children born within kind of family, due to kind of adult male family members. And so the efforts are mostly child and adolescent focused because there's a lot of care homes on the island. What's interesting about Grenada, there's 101,000 Grenadans on the island, and there's 127,000 living in Brooklyn. So there's this hope that there could be some diaspora support around like how to do this culturally, in a culturally competent way, but it's a new initiative. And what's great about it is St. George University, which famously kind of during the, is this big medical school down there, but the psychology department, which was only undergrad, the core faculty, which are a large majority are Grenadian, decided to launch a community psychology master's program to serve the island. They're all doing it pro bono. They all each took 2 or 3 classes each to build a master's program. And it loops back to this idea of they want help with, they can teach the courses, but they're not really working clinically. They want help with clinical supervision. They want to help with kind of current kind of best practices for trauma work. So we want to, kind of the partnership would be to send down clinicians who could help with the supervision of the master students who will stay on the island. So yeah. All right, well, we bumped into our time. I believe my PowerPoint is going to be disseminated. My email's on there. Feel free to reach out. Do you have any last words? Okay. All right, thank you, everyone.